Our next speaker, let's all welcome Dr. Amit Thapa from Nepal. He will be discussing hemostasis in UBE.
Respected chairpersons and dear friends, a very warm greetings from Nepali Society of Neurosurgeon. I am the current vice president of the society, and I would like to thank the organizing team, particularly Dr. Malcolm, for having me here. And I should actually bow to his efforts, relentless efforts from him and his team to bring all these stalwarts together. I feel this is the best place to learn about minimal invasive surgeries, tubular as well as endoscopy. Well, I bring here with a topic which I think is very relevant, not only for the beginners, but also for the experts, because I feel that surgery is nothing but training your reflexes. And if we have a checklist just like a WHO checklist for surgical safety as to what to be done for preventing a bleed as well as what to do at the time of bleeding, that's going to not only save your time of surgery, but also leads to a lot of complications avoidance, which I will be discussing in few minutes. Well, I have nothing significant to disclose related to this presentation. So UBE is a bloodless surgery, and that's why the reason I actually took this surgery over the tubular surgeries, which I've been doing for the last 2 decades. The benefit is definitely of the hydrostatic pressure, which prevents the epidural venous bleed. The water as a medium washes off the blood, and that's why it provides a clean feel. But then what you need to remember that because of the vortex movement of the water inside the cavity which we have created, the platelets do not have enough time to clot the blood, as well as the blood is pushed inside the tissues, which causes the hindrance of the epidural bleed. So these are the caveats one must remember as to use of the irrigation when we are trying to control the bleeding. Now, why I choose this topic? I actually did a little research on the Google as well as in the PubMed as to what are the recent publications on the bleeding. And to my surprise, I didn't find any single publications of the bleeding. There were much more talk of the hidden blood loss, but then there was no talk on how much, what all procedures are actually recommended, and has there been any scientific publications on this particular thing. And this is every beginner's nightmare. We all know about it because blood absorbs light. It actually obliterates the vision because of this. And in the zest of trying to control the bleeding, we actually cause much more injury by inadvertent use of diathermy. Irrigations leads to hypervolemia and tissue edema. And also it prolongs the surgery, and at the end it frustrates the surgery, and that's why most of the surgeons, even after learning a very good technique, actually fails to use it in their practice regularly. So we should also know what bleeds. Now, when we talk of bleeding, there can be two categorizations, either a visible bleed or an invisible bleed. So the visible bleed actually is the excess-related bleed when we are trying to reach the space of sun. So there are bones, there are soft tissues, and it has been published in the literature by Go et al. That the amount of the bleed is actually depending upon the thickness of the muscle you need to access through to reach the space of sun. And of course, we all know about the vascular supply over the bone, and which are basically supplied by intra-articular artery, superior articular artery, and inferior articular artery. And if we see the scope which we are placing in the UB technique, intralamina approaches, it's at 9 o'clock, 7 o'clock, and the 6 o'clock position, which actually bleeds from the bone, and that's why we have to be cautious about these particular sites of bleeding whenever we are using any RFA devices over it. And similarly, when we reach inside, then there is an epidural bleed which can occur. What is also important to us to understand is the hidden cause of the bleed, like increase in the venous pressure, which can be because of the result of the increase in the abdominal pressure, as well as coagulopathy, which we may have missed the whole thing. So as adage goes, prevention is better than the cure. We should always start with checking of the coagulation profile of the patient. We should stop all anticoagulants and antiplatelets. We should be giving two different point of checks when we are trying to position the patient. Not only the surgeon, but also the anesthesiologist should check whether the abdominal pressure is relieved. And then to maintain adequate pressure inside the cavity, we should be trying not to create a lot of facial punctures. This usually occurs when the beginners is starting, when we are trying to push in the instruments inside the instrument port, we actually create a lot of facial punctures, and that's what actually seeps a lot of water outside the cavity and does not allow a sort of a pressure built up inside the cavity. And also we should try to keep the exit port as small as possible, and that's why nowadays the semicircular or semi-open sheets are available to push your instruments inside the cavity. Now, when the bleeding occurs, we should always start communicating with an anesthesiologist. We should try to keep the blood pressure, particularly it has been recommended that the optimal systolic blood pressure during the local and general anesthesia is 90 to 100. For the local anesthetic procedure, it should be 120 to 130. We should also try to decrease the inspiratory pressure or PEEP, and if in case patient may have bronchospasm, so if in case the patient does not have a very normal inspiratory pressure, we should also try to rule out bronchospasm. And sometime when the anesthesiologists are trying to put the CVP line, patient may have developed a pneumothorax or may have developed some compression over the abdomen during the positioning, so this needs to be ruled out. And of course, we should also ask our floor nurse to start recording the bleeding time as well as the durational time. This is very, very important when we are raising the height of the irrigation fluid to control the bleeding. We forget that the pressure is very much high inside the cavity. And that's why, as a general rule, we should always keep that pressure high, but not more than 1 to 2 minutes, because if in case we are trying to do that, this means we are flushing the blood off very fast, and that's why the patient is losing blood even though we may not realize it. Then there are medications like tranexamic acids, which can be used throughout the surgery to control the bleeding, and also hemostatic matrices like flow seal. Nowadays, flow seals are coming in the liquid form where you can put it through the nozzle inside the epidural spaces, particularly to control the bleeding. And then there then be many instruments like diathermy. Nowadays, the diathermy has been taken up by the radiofrequency plasma coagulation, which does not allow the temperature to go up, and it actually creates a very good feel after some time. Only point to be noted is we should try to use this RFA towards the periosteum so that we do not pull off the epidural vessels, which can get stuck to these RFA devices. And of course, on the bone, we can actually apply bone wax. Diamond drill has been shown to be very effective in controlling a little bit of bleed oozing from the bone. If you can apply the bone wax over these sites and then use the drill over it, it actually controls the bleeding. So Dr. Om Prakash, I think he must be in the audience, he actually showed a very good technique how you can apply a bone wax using a small shunt tunneler passer. But this is applicable when you are putting it over the surface which is exposed to you. If the bleeding is coming from the down, you can actually use a pen field, a curved pen field with a small bone wax plug onto its tip, or you can even use the small bone wax plug attached to the foot plate of the bone ronger, and then use it to plug the small bleeding from under surface of the bone cut surfaces. Then, of course, the irrigation pressure, we should be aware that the pressure which we are talking about, 30 to 50 millimeter mercury, may not be actually be pressure built up inside the cavity, because the water is flowing out. And that's why the pressure built up is not so high. So if you have to create a little bit of more pressure, the first and foremost thinking is you can actually close the egress. So you can actually use a finger to close the exit of the water so that the pressure builds up inside the cavity. And then, of course, you can control the vortex movement by this, and then you can also increase the irrigation process pressure. Then we can use the scope. The scope has to move out a little bit outside so that it does not get soaked up in the blood. And we can use a 30-degree scope in these particular phases, because 30-degree scope by an eccentric view, you can, by its movement, by rotating movement, you can have an extended field of view vision on the operator side. And if nothing works, then of course, you can actually call your seniors, and your non-endoscopic colleagues can also be a help of them. You can convert to open surgery and use microscope and keep your blood products ready and transfuse if necessary. We have to repeat hemoglobin, coagulation profile, and ABGs. And remember, these are the patients where hypothermia, acidosis, and coagulopathy needs to be prevented at all the times. Of course, once the bleeding is stopped, you should always bring down the pressure and always see whether the bleeding stops while the irrigation has been stopped. Sometimes these bleedings are hidden by the continuous irrigation, so one should be aware of this. Other term which I like to put forward is the hidden blood loss. This was actually being talked about nowadays. So hidden blood loss is nothing but the subtraction of the total blood loss minus visible blood loss. And it has been shown that the blood loss which we estimate after the surgery is severely underestimated because of the use of continuous irrigation, blood infiltrating into the soft tissues, and even the blood which is going inside the dead space in the surgical channel. So in one of these paper where they have done the blood loss, hidden blood loss calculation for the patients who had undergone UBE technique surgeries for simple cases like canal stenosis and discectomies, it has been found that the hidden blood loss has been around 361 plus minus 217 mils. That is almost half a liter in the maximum amount of the cases. And it has been 3 times more than what surgeons calculate in the visible blood loss. And it has been shown to be directly proportional to the operation time and the paraspinal muscle thickness. So to conclude, whenever we have these types of situations, we should keep our calm. We should not intervene in panic. Think what causes bleed, so we can come from up to down, and then we can start taking preventive steps before we use a stepwise management. And also, whenever we are trying to going to close the wound, we should always reassess so that the patient is not bleeding from any other sides. Thank you for your patience listening. My email is here. We can always communicate on this topic. And I would like to use this flora to invite all of you to the Neurosurgery in South Asia Advances Achievement in Future Collaboration. So basically a SARC meeting to be held in Kathmandu from September 7 to 9. And we will have a session on spine endoscopic techniques in this meeting. Thank you very much.
Thank you, Dr. Amit Thapa. Wonderful, wonderful lecture, and thank you for keeping in time.